Welcome to Community Cares and Project Echo. Today's session is on breast cancer screening. I have to figure out how these slides, okay. So this is just a quick disclaimer that the information contained in this presentation is not substitute for a medical consultation, and a physician should always be consulted for any health problem or medical condition. Today's agenda. So we're going to do a Project Echo series overview, introductions, the presentation, a case study, and we'll do questions and answers at the end. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. For more information on Project ECHO, you can visit echo.unm.edu. So today, our speaker is Dr. George, an associate professor of medicine. She will be doing the presentation, the didactic portion, as well as the case study. I have her bio on the screen in case anyone would like to read along, but Dr. George is a medical oncologist in the breast oncology program at Rutgers Cancer Institute. As part of these multidisciplinary teams, she's committed to providing the most advanced and comprehensive care to her patients. She completed her hematology oncology fellowship at Rutgers Robert Wood Johnson Medical School and thereafter joined the faculty as an assistant professor of medicine. Prior to that, she received her undergrad degree from Rutgers University and her medical degree from Rutgers Robert Wood Johnson Medical School. She completed her internal medicine residency at University of Massachusetts, and she is now an associate professor of medicine. So now we're going to talk about breast cancer screenings. I'll pass it to Dr. George.
Thank you, Sarah. Thanks everyone for joining the session this morning. So we're just going to talk briefly about breast cancer screening. Next slide. So just a pre-test, we'll go over the answers at the end. I think the questions pop up on your screen. If you could answer these questions.
We'll just give it a little bit longer, Dr. George, to get more answers. Oh,
Sure.
we've reached our threshold. You can move on.
All right. Next slide. All right, so the outline for the study presentation today, we'll talk about what is the risk of breast cancer in women, what is the role for breast cancer screening, and what are the current screening guidelines, and how they're, and we'll discuss the screening guidelines for women at elevated risk for breast cancer. So what is the risk for breast cancer? So this was one of the pre-test questions. About 1 in 8 US women will develop breast cancer over the course of her lifetime. So there are 19 of us. If there are, unfortunately, if there are 8 women here, 1 in 8 women will have some history of invasive breast cancer over the course of their lifetime. And on average, every 2 minutes, a woman is being diagnosed with breast cancer in the United States. According to the 2025 estimates, it's about 317,000 new cases of invasive breast cancer will be diagnosed in the US. In men, it will be about 2,800 new cases. And 42,000 women are expected to die from breast cancer just from this year alone. The rates have, however, been decreasing since 2007, and the death rates have been steady in women under 50, but in women over 50, they have been decreasing. Besides the rate of 1 in 8 women have been diagnosed with breast cancer, there are familial genes such as the BRCA1, BRCA2, which are germline mutations, and in women who inherit one or more of these genes, the risk of breast cancer is much more elevated. About 5 to 10% of breast cancers are linked to some of these gene mutations. So this is some of the statistics on the incidence of cancer. As you can see in women, breast cancer is the most common malignancy that is diagnosed, as you can see in the estimated new cases table. But if you look at the table below, and we look at the estimated death in women, breast cancer is the second leading cause of death after lung cancer. Lung cancer is the second commonly diagnosed cancer in women, but is a leading cause of death in women. Breast cancer is diagnosed every 29 seconds around the world. In the US, it's about 2 minutes. It's estimated that 86.4% of people will survive 5 or more years after being diagnosed with breast cancer. And that's mostly due to the advances that we have made in some of our treatment regimens for this disease. Um, and they're estimated to be about 2.8 million breast cancer survivors in the US. Next slide. So there are risk factors for breast cancers. However, there are non-modifiable risk factors and modifiable risk factors. Non-modifiable risk factors are things that cannot be changed, such as the gender, age. The risk of breast cancer is much higher as women age, so age over 45. If a woman has a germline mutation, such as a mutation in the BRCA gene, PALB2, ATM gene, if there's a family history of breast cancer, that is non-modifiable. Personal history of breast cancer, race and ethnicity, the density of the breast tissue, if there is an incidence of benign breast conditions such as DCIS, history of LCIS, also the duration of the menstrual period. So early menarche is if they have early period and late menopause, that is a non-modifiable risk factor for breast cancer. History of prior chest radiation for a different type of malignancy, or exposure to DES as an embryo when the women was pregnant. Modifiable risk factors include not having children, so that increases the risk for breast cancer. The use of oral contraceptives is associated with a slight increase in breast cancers. Depo-Provera is another contraceptive that also increases the risk of breast cancer. The use of hormone therapy after menopause to combat menopausal side effects is also associated with an increased risk of breast cancer. Breastfeeding is linked to a decrease in breast cancer risk. However, I mean, I get these questions from women all the time after they're diagnosed. Does breastfeeding protect you from breast cancer? Unfortunately, no. It does reduce the risk compared to someone who did not breastfeed, but does not eliminate the risk. So there's always a risk of breast cancer, even in women who previously breastfed their children. Alcohol consumption is linked to an increased risk of cancer. Obesity, lack of physical exercise is also linked to an increased risk of breast cancer. If women are physically active, it's linked to a risk reduction. So we'll just talk about the role of breast cancer screening. So screening refers to tests and exams that is used to find a disease in people who don't have any symptoms. So we get this question commonly from patients, why do I need to do these tests? I feel fine. But the goal of screening is to identify or pick up a disease before it causes any issues and to treat early. So the goal of screening for breast cancer is to find it early and before it causes any symptoms like feeling a palpable mass in the breast. And early detection means finding and diagnosing a disease earlier than if someone had waited for the symptoms to start. Breast cancer found during screening are more likely to be smaller, less likely to have spread outside the breast. The size of the breast cancer and how far it has spread are some of the important factors that is very essential in predicting the prognosis of how a person is going to do with the diagnosed breast cancer. We have women who get mammograms every year, and they've been good for over 20 years, 25 years. But for some reason, a screening mammogram that was done recently picked up an abnormality that was not seen in the last 25 mammograms. So it is important to get mammograms every year, because that's the best way to catch something early and treat it before the symptoms appear. So for screening guidelines, there's clinical breast exam. We recommend that women follow up with their gynecologist or their primary doctor to do a clinical breast exam. A mammogram is what's routinely used for screening, and it is a breast X-ray. So just like people get chest X-ray, a mammogram is a different version, but it's an X-ray of your breast. Breast MRI is different from an X-ray. It uses strong magnets instead of X-rays to create a more detailed image. Because of this, breast MRIs are more detailed, picks up more details than mammograms. But breast MRIs are not routinely recommended for screening. It's going to be mammograms that is routinely recommended. Breast ultrasound is often ordered when a woman palpates a breast lump. Is not, however, recommended for routine screening in breast cancer in the general population who do not have a breast lump. We do include breast ultrasounds in women who have an increased breast density. That's usually discussed with their doctors. And so, but breast ultrasounds are not routinely done. It's only done in women who have an increased breast density. So, um, if you look at the age-adjusted mortality rates, for some of the time screening was instituted somewhere in the late 1980s, about 84,000 to over 500,000 lives have been saved because of cancer being caught early as a result of increased breast cancer screening. So this study, the Pan-Canadian study, looked at breast cancer deaths in women who had not done any screening mammograms to compare to women who did not do any mammograms. So there were 2.8 million women who were identified between 1990 and 2009, and they saw that there was an average breast cancer mortality reduction of about 40% in women who had mammograms compared to women who did not. The risk varied from different ages between 40 and 49, 50 and 59, and 60, 69 was over 40% reduction in mortality. So it's actually reducing the incidence of breast cancer related deaths. This did go down to 35% in women between 70 to 79. Screening mammograms past the age of 65 is usually a discussion with the primary provider, and also depends on other health conditions that women may be facing. What are the benefits of screening? It does result in breast cancer mortality, like we just discussed. If we pick up cancers early, there's less extensive surgery needed for screen detected cancers. If a cancer is detected based on a physical exam where a woman palpates the lump, it is already much larger, and there is a chance that it already started spreading to the lymph nodes. When women have very early stage, we can potentially avoid chemotherapy, even in the more aggressive cancers. If tumors are less than 5 millimeters, we're able to omit chemotherapy. So there is a benefit in picking up cancers very early. However, if patients do need chemotherapy, chemotherapy is very effective in screen-detected breast cancers. So we'll just go over some of the breast cancer screening guidelines as dictated by various organizations. So I know it's hard to read the slide, but there are various organizations that have put out recommendations for breast cancer screening, but most of the current guidelines do recommend screening starting at age 40. The different societies vary on how often it should be done. So the PSTF recommends every 2 years in women 40 to 49, and then increasing it to every year. But then, the American Cancer Society, they recommend doing every year starting at age 40. The American College of Obstetrician and Gynecologists, they recommend once a year or once every 2 years through shared decision making. So the screening guidelines do vary between the different societies. So, but more commonly, we are recommending yearly mammograms starting at age 40. So if you look at what are the reductions in risk of cancer, if we do screen yearly mammograms versus every other year. So if you do yearly mammograms from age 40 to 84, there's a 40% reduction in the risk of dying of breast cancer. The number of lives saved per thousand women is about 11, almost 12 per thousand women who've had screening. And the number of life years gained per thousand is 189 life years that are gained. So as you can see, if you do yearly mammograms, the reduction is much more significant and more lives are saved. That's the reason we do recommend doing yearly screening mammograms. If patients are doing every other year screening mammograms, the reduction in risk of dying is about 23%. And the number of lives women whose lives will be saved per thousand women is about seven women. And the number of life years gained per thousand is 110 life years. So again, this slide is talking about the importance of 40. 40 is an important number. All women 40 and older should get annual mammograms. It can reduce the risk of breast cancer death by about 40%. The breast cancer incidence for ages 40 to 44 is twice that of 35 to 39. So it is very important. In women between 45 and 49, it's about 189 patients per 100,000 women and continues to increase until the age of 80. So 40 is an important number. To anyone's turning 40, if you have friends or families turning 40, please encourage them to do mammograms. Just because they're 40 does not mean that they're too young to get breast cancer. We unfortunately see many patients who are very young and otherwise healthy being diagnosed with breast cancer. So one of the common questions we get is, oh, when I go for mammograms, I'm going to get a recall. It is not very common. It's about 10%. And even with the recall, we usually get repeat imaging and biopsies about 1 to 2% per year. So if it does not mean that you will have to go for additional imaging and biopsies just because you're getting a mammogram. They try to get screening mammogram if there is something concerning. Then they get a diagnostic mammogram to get more information, and if that looks fine, they may do a 6-month mammogram or a 1-year mammogram. So the recommendations are to start at the age of screening yearly mammograms at the age of 40 because it will reduce breast cancer deaths by about 40. Yearly screening mammograms starting at age 40 versus every other year's screening starting from between ages 50 and 74. It approximately saves 14,000 more lives each year. So that is a significant number. That's the reason we do strongly recommend doing yearly mammograms from the age of 40. We'll just switch gears. We'll talk about screening guidelines for women at a higher risk for breast cancer. So there are certain genes that are inherited that does unfortunately increase the lifetime risk of breast cancers. Some of the genes are listed in this table. They are BRCA1, BRCA2, TP53, PTEN, PALB2, STK11, CDH1, ATM, and CHEK2. If you can see BRCA1, the estimated lifetime risk is very high, about 55 to 65% chance that a woman will develop breast cancer over the course of her lifetime. Similarly, BRCA2 slightly lower than BRCA1, but still very high, for almost 50% estimated lifetime risk of breast cancer. Currently, when women are diagnosed with breast cancers, we do strongly encourage genetic testing to determine if they have one of these inherited genes. And the screening guidelines are relevant to their family members, because once they get tested, we will encourage them to get more frequent screening to pick up breast cancers, especially when they're much smaller. Next slide. There are also other models that are used to identify women who are at a higher risk for breast cancers. In addition to the genes that we just talked about, there are women who are at a higher risk based on their family history, the breast density, prior history of any abnormal, benign breast conditions. And when we plug in all that information, there are different risk models that can be used to identify women who are at a higher risk for developing breast cancer. And this is completely separate from one of these inherited genes. And in women that are at higher risk for breast cancers, we do recommend more frequent screening. We also discuss pharmacologic options such as tamoxifen, letrozole, or aromatase inhibitors such as anastrozole to reduce the incidence of breast cancer over the course of their lifetime. So in terms in if there is a known genetic mutation or if their lifetime risk is greater than 20%, we do recommend mammograms starting at age 30, MRIs annually starting at between ages 25 and 30. If there is a history of breast cancer and if they have dense breast, and if there is breast cancer history diagnosed at less than age 50, then we do recommend mammograms starting at the time of diagnosis and MRIs as well, starting at the age of diagnosis. If there is history of chest radiation before the age of 30, unfortunately, this does increase the risk of breast cancer. So they are recommended to get mammograms at age 25 or 8 years after therapy, whichever is later. And they're also recommended to do MRIs between ages 25 and 30. If a person has a history of one of the high risk lesions such as ADH, ALH, LCIS, or a personal breast cancer history other than what is listed above, then they are recommended to start mammography at the time of the diagnosis of one of these, at the time of diagnosis of ADH, ALH, or LCIS, or any other breast cancer history. And MRIs also are recommended. However, it's not recommended for all women, MRIs, but MRIs is strongly recommended if there is a personal history of LCIS. So just going to talk about case study. I know we've been talking about screening mammograms. I'm just going to briefly talk about ctDNA. ctDNA is circulating tumor DNA, and it's an evolving field in breast oncology. And I'll just talk about how it has helped some patients based on an ongoing clinical trial. So the patient's a 50-year-old postmenopausal woman. She previously never had screening mammograms. She palpated a mass in her left breast, and she noticed that her skin was also turning red where she palpated the mass. So she eventually was seen by a breast medical oncologist, and she was diagnosed with an aggressive form of breast cancer called inflammatory breast cancer involving the left breast. She had a very high stage at the time it was diagnosed, clinical stage 3B. If you know the cancer staging, it works from stage 1, 2, 3, and 4. Stage 4 means that the cancer has spread to other parts of the body and it's not curable, but stage 1, 2, and 3 are still curable. So she had a high stage 3B at the time of diagnosis. And if you look at some of the other key parameters, we understand that she had a very aggressive cancer. She had a grade 3 disease. She was hormone receptor negative, so estrogen receptor negative and progesterone receptor negative, but HER2 positive. Given that she was HER2 positive, she was treated with chemotherapy as well as HER2 targeted therapy prior to surgery. So that's what's referred to as neoadjuvant systemic therapy. And based on these treatments, she did have clinical response to her treatment. Next time, yeah. So we she was enrolled in a clinical trial that was looking at circulating tumor DNA. So when she was first diagnosed, she had detectable circulating tumor DNA, and as you can see, the number did go down over the course of her treatment. But even at the end of her treatment, she still had some circulating tumor DNA. Just to put it in perspective, in patients with less aggressive cancers, usually with the treatment that we give, neoadjuvant chemotherapy. So NACT is neoadjuvant chemotherapy, treatment that's given prior to surgery. They're able to completely clear the circulating tumor DNA and become zero prior to surgery. But in this situation, this patient still had detectable circulating tumor DNA, but after the completion of her neoadjuvant therapy, she proceeded to have surgery. Next slide. So given the aggressive nature of her cancer, she needed a unilateral mastectomy, and she also had removal of the lymph nodes in the axilla, that's known as ALND, or axillary lymph node dissection. So good news for her: at the time of the surgery, there was no cancer that was noted in the breast or the axillary lymph nodes. So she had an excellent response to the treatment that was given. Next slide. However, when we looked at the circulating tumor DNA, especially after surgery, saw that the number was going up. So in spite of having surgery and not detecting any cancer in the breast or the lymph nodes, there was some tumor DNA being shed into the bloodstream, which was very concerning because there are studies that show that if patients have ctDNA that is trending up, they are at a very high risk for stage 4 breast cancer. So as part of the trial, based on this information, we could change treatments in post-surgery to see if that would improve her outcomes. Next one. So based on that, we got insurance approval to treat her with a different type of HER2-targeted therapy called adotrastuzumab, or TDM1. So based on that, you see that her numbers did go down significantly because of the change of treatment, and her ctDNA became undetectable just after a few cycles with the new regimen. And she continued to be a negative over the course of her treatment. I just wanted to talk about a new evolving area in breast oncology. So this is a new field, and a lot of clinical trials are being done to better understand how this piece of information can be incorporated into imaging to understand how best to help our patients. So circulating tumor DNA, just to go over it, so there are cancer cells, and as cancer cells break down, it releases tumor DNA into the bloodstream. So this tumor DNA that's being released into the bloodstream by the cancer cells is referred to as circulating tumor DNA, and it's a dynamic real-time biomarker, so it can be measured every week, every few weeks, to understand how a person is responding to their treatment. And the half-life is about probably less than an hour, depending on the sensitivity of the assay. So we need very powerful assays to detect these tumor DNA, and it's usually a blood test that takes one tube of blood and is sent to the labs to calculate these numbers. They usually give us numeric values so we can see how these numbers are trending week by week, especially as they receive their treatments. Next slide. So to understand some of these, we have ongoing clinical trials that are happening at the Cancer Institute. Exact-ctDNA 003, or NACBP64, is a national study that is enrolling patients who are newly diagnosed with breast cancer. And if they're receiving neoadjuvant therapy for their breast cancer, they are eligible. So we're strongly encouraging our patients to sign for the study. because they are donating blood during the treatment period, post surgery, and for up to 5 years, so that we can understand how circulating tumor DNA changes over the course. And are we able to use this information to identify women who are at a higher risk of recurrence and maybe intervene early in order to prevent stage 4 breast cancer? As you all know, stage 4 breast cancers is much worse than stage 1, 2, or 3. So, is there anything we can do to delay the progression or prevent stage 4? That's the question that will eventually need to be answered. But right now, we're trying to understand more information how ctDNA behaves, how sensitive these assays are. There are various companies that are able to do ctDNA testing. Octane study is a study that's for early stage triple negative breast cancer that's done at Rutgers, and it's enrolling patients. Cypher study is another study that recently completed enrollment and was just looking at how ctDNA changes in patients who are receiving chemotherapy prior to surgery for their triple negative or HER2 positive early stage breast cancer.
Thank you so much for that, Dr. George. That was really interesting. I had no idea that was all happening. Evelyn, do you think we should do the Mentimeter still, or should we just go into questions? I can't see the chat.
We have one question. I had a question as well, but Dr. George sort of answered it in her second slide about the ctDNA. So we do have a question. Maybe let's do the question and then go into Mentimeter.
Hmm.
What do you think? Okay. So Dr. George, we have a question here. What is the difference of HRT, hormone replacement therapy, to reduce symptoms of menopause, in parentheses, which is related to increased breast cancer, end parentheses, compared to HR positive treatment to reduce breast cancer?
Okay, yeah. So that's a very good question. It's very confusing to patients who don't understand what these acronyms mean. And as physicians, we use a lot of these acronyms in our notes. So HRT is hormone replacement therapy. So in women who do not have a history of breast cancer, unfortunately, given their symptoms of, hot flashes, unable to sleep, they may discuss starting low doses of estrogen or progesterone, which are female hormones, in order to alleviate some of these symptoms that they're having because they just entered menopause. And HR positive, so HR positive means hormone receptor positive breast cancers. So these are cancers that are using these hormones to grow. So unfortunately, these cancers are using the female hormones such as estrogen and progesterone to grow. And so when we are treating patients who have HR positive or hormone receptor positive breast cancers, we are trying to reduce the hormone levels, not actually give hormones back to patients, because God forbid they have a small cancer cell still somewhere in their bloodstream after surgery and after radiation. We need to cause those cells to die by eliminating the source of the hormones. So we are using medications that either reduce the hormone production or block the hormone from binding to these receptors, the different classes of medications that are used. So that is the treatment for HR positive breast cancers. In patients who have HR positive breast cancers, we do not recommend using HRT or hormone replacement therapy, because you're actually giving hormones which can feed the cancer cell if there is a small cell somewhere in the bloodstream. So we don't want that happening. So we tell our patients you cannot go on oral contraceptives that use hormones. They can't use patches. So hormone replacement therapy is not an option in women who have a history of hormone receptor positive breast cancer.
Thank you. That makes so much sense now, because you're managing the hormones in both situations. So my original question was, is ctDNA going to be given to survivors to check for recurrence? But it looks like you addressed that. So in that, my follow-up, I guess, would be, do you think there's a future for this ctDNA testing to replace mammography?
So ctDNA testing is being done in women who have breast cancers. So it's usually so we do it in breast cancer. Mammography is also being done in women who have no history of breast cancers to pick up cancers. It's hard to answer that question at this time. We don't have. I mean, it'll be a different version of ctDNA probably in the future, but it's going to be a while. There are companies looking at blood tests, not just to detect breast cancers, but also other types of cancers. They are still evolving. So it hasn't entered our guidelines. Before we institute recommendations for all patients, we need to understand the risk benefit of every test. We want to make sure if patients are doing these tests and not doing mammograms, we are accurately identifying patients who are at an increased risk of breast cancer. We don't want to miss the chance. We could probably use mammograms and these blood tests. We're not sure what the future is going to be. We need a lot of clinical studies to be done. We need the results from the clinical trials once the study has completed enrollment, and in order to understand the benefit of some of these blood tests. But it could be the future in, say, 15 to 20 years.
I think probably every person here who has to have mammography would sign up for a clinical trial if they had all they had to do was submit a blood test for breast screening.
Yeah, there are GYN offices actually doing some of those studies. I've seen it in my GYN offices as well. So, I mean, look around, you'll find clinical trials that are being done to understand this.
Thank you.
Thank you. If we don't have any more questions, we can move on to the Mentimeter and then we'll come back and do the post test. But if you do have questions or you have questions later, this will all be posted to our Mighty Network, so you can ask over there and I can send the questions to Dr. George to answer as well. So I'm going to stop sharing my screen and then open the Mentimeter. You can scan the QR code. It's just 5 questions.
Sarah, can you put the link in the chat?
Yes, 1 second. Mm. And I know you can't see my screen yet, but I'm trying to, okay, share. All right. So the first question that I had for everybody is, what surprised you most about today's breast cancer presentation? Yeah, the statistic of 1 in 8 women. I also have never heard of ctDNA, so it was really interesting to hear about. Yeah, I knew the ctDNA when I saw those slides. I was like, yeah, this is going to be really interesting. I'm glad everybody's agreeing. These are all great answers. Hormones can really be our best friend and worst enemies. Mm-hmm. Yeah, the rate is 1 in 8. Thank you for sharing. Yes, agreed with all of these. So the next question I have for you guys, there are a series of 3 questions, but how confident do you feel talking to your patients or your community that you serve about breast cancer risk and screening? How confident are you in discussing breast cancer resources with your patients or the community that you serve? And how confident are you in advocating for breast cancer awareness in your community or workplace? So it goes from not confident to confident. I'll let a few more people answer. 15 out of 19 people. Okay, we can move on to the next question. So, what barriers do you see in your community when it comes to breast cancer screening or treatment? Yes, insurance is a big one. Transportation. Yep, lack of knowledge. Taking the first step to get screens, need to identify why women are not wanting to get screened. Though some people don't like the mammogram because it's painful. Patient education, lack of education around screening and resources, early detection for high risk population. Yep, I see insurance a lot. Yep, transportation, fear, education. Guess that kind of goes into my next question. So, what myths or misconceptions about screenings come up in your outreach or things that you've just heard about breast cancer screenings, screening in general? Yeah, people scared of radiation have definitely gotten that too. Yeah, mammograms cause breast cancer. Yeah, a lot of misinformation. Oh, you don't need screening if there's no family history. Yeah, radiation fears. Women will say they don't feel anything during self-exam, so they don't need to get a mammogram. Mm. Yep, that men can't have breast cancer. Definitely have heard that one too. Yeah, people say, "Can I eat well? I'm gonna be okay." Definitely, I've heard the there's no family history, so I don't need to do it. So, what type of support would help you most in addressing breast cancer in your work? So, these are some of the options: more training, patient education materials. I know that came up too, that people are unaware, referral resources, community partnerships. So, a lot said community partnerships. That's great. This is why things like this are so important. We're all introducing ourselves in the chat, making connections, patient education materials, everything that we talk about will go into our Mighty Networks folders. That's all the questions I have. Thank you all for participating. And then we can go back to the slides.
Dr. George, while we're pulling up the slides, are there any misconceptions you've heard that you didn't see in our Mentimeter?
No, those are all good ones. I've heard all of them, I feel, at some point.
If anybody has any other questions, we can ask them now. You can put in the chat or you can unmute if you'd like. If not, we can move forward with the post test. Dr. George, do you want to go over the post-test?
Sure. Do we have the results from the pretest?
No, we need to wait for the results for the post test. So let's give it
Oh,
a
got it.
minute.
Okay. So, yeah, both answers are correct. So 1 in 8 women will develop breast cancer over the course of their lifetime. And what's the main goal of breast cancer screening? It's to detect breast cancer early when treatment's going to be more effective. In some cases, we can avoid some aggressive treatments such as chemotherapy if cancers are detected much early on. So earlier stage, so stage 1 breast cancers. But it varies from cancer to different it varies by the subtype of breast cancer.
So in the pretest, we did have a few people that got number one wrong. So I'm really excited to see that we got 100% in the post test because that means that people learned something today.
Yeah, that's great. I'm happy to take any questions any of you have regarding breast cancer screening or anything that you can help patients, especially after they have an abnormal mammogram. Happy to answer any questions about that.
All right, then if someone has a question, can they reach out to you?
Sure.
Okay, I have your email posted, I think, in the beginning slide, so I'll make sure to put that in.
There's another question in the chat. Um, Janet, do you want to unmute?
Oh, yes, I can. Yeah, it would be better.
Janet, you're muted.
Oh, okay. Can you hear me now?
Yeah.
So this is regarding the woman who had the unilateral surgery, the mastectomy. Could have been a different outcome if she had double mastectomy in the sense that she wouldn't have the ctDNA. No, no.
No, because ctDNA, so she had cancer in one breast. It's very common for cancer to spread to the contralateral breast. It's more likely to have spread somewhere else in the body. More common areas are the bone or the lung. The contralateral breast is less common compared to lungs, bone, liver, or other lymph nodes in the area. So in this situation, I don't, a double mastectomy would not have eliminate a ctDNA.
Okay, thank you. Thanks.
And there's another, once someone has their breast removed, how are they screened moving or going forward? That's a great question.
Yes, good, very good question. So it depends on the type of reconstruction. So in patients who have mastectomy, some women just opt to go flat. They do not require any additional imaging. They do, however, follow up with their oncologist given their history of cancers, and we do a physical exam where we feel that area, the surrounding lymph nodes to make sure that we're not feeling anything abnormal. In women who have a mastectomy with implants or autologous reconstruction, basically taking a tissue from another part of the body to create the breast mounds. Again, we do not recommend mammograms in those situations as well. We do physical exams just to feel the area. We do encourage our patients to get a feel for their reconstructed breast so that if they feel anything abnormal, they notice a new lump, they will reach out to their providers. We do order ultrasounds in women who have reconstructed breasts just to pick up anything abnormal. If the ultrasounds are suspicious, then we go for MRI.
Now, is the ultrasound part of regular screening or that's only if they feel something?
If only if it's abnormal. So it's not routinely done. Again, that also varies from surgeons to surgeons. I've had some surgeons who do recommend doing ultrasounds once a year, but then most surgeons do not recommend any additional screening. after patients have a mastectomy.
Interesting. So if anybody has any other questions, we can put them in the chat, but I'm gonna just go over the last few slides. About NJC, we'll put all the information in the chat, but they do provide free screenings all over New Jersey for breast, cervical, colorectal, and prostate. And thank you so much for attending today's session. So please let us know how we did. The link will be in the chat, but also you can scan the QR code. We really do look through all the evaluations. So please, if you have some time, we'd appreciate if you could fill it out for us. The link will be in the chat. And then again, all of our information, all of the recordings, the resources will be posted to our Mighty Networks community. This is a great platform. If you have something you want to share too, please feel free to share it on the Mighty Networks community. And then November, we're going to be doing a session on financial wellness for survivorship. I believe that's all I have for you guys today. Thank you. Thank you for attending.